It's my great pleasure and honor to welcome all of you to the 12th annual Isidore I. Ben-Ruby Lecture. For those of you I don't know, I'm Linda Freed, and I have the honor of serving as the Dean here at Columbia University's Mailman School of Public Health. And today, I particularly have the honor and privilege to welcome our longtime friend and colleague, Dr. Mary Bassett, New York State's Health Commissioner, to deliver the Ben-Ruby Lecture this afternoon. My colleagues, Dr. Ron Baer and Dr. David Rosner, will introduce Dr. Bassett shortly, and she'll join us then at the podium. This week is Public Health Equity Week at Columbia Mailman School, where we have been coming together and will come together all week as a community to participate in programming, to learn from experts, and to think together about how we can best move the needle forward to end health disparities for all populations. As a public health leader and champion for health equity, Dr. Bassett, I know, will push us today to consider our place in achieving health equity. This year, our school, one of the 3 original schools of public health in the United States, celebrates its centennial. As we begin now the 2nd century of public health, we ask ourselves, how can we most effectively create health equity in a world of widening disparities? Columbia Mailman Center for the History and Ethics of Public Health, founded by Drs. Baer and Rosner, is addressing and always addresses this very question with its unique collaboration of historians and ethicists. The center, housed in our Department of Sociomedical Sciences, is the first and only program of its kind. The program uniquely merges historical research and big data and is a central part of our school's core curriculum. The study of history and ethics is, of course, highly relevant to our 2nd century of public health. We cannot make effective public health decisions for the public good without the knowledge of our past history as well as an ethical rudder. We're so proud and been so much the beneficiaries of the work of the center as it builds bridges from evidence to policy and into our communities based on this knowledge. We're able to gather here today because of the generosity of the Ben-Ruby family. The Ben-Ruby family's gift to establish this lecture series has allowed us to welcome the world's leading minds at the crossroads of history, government, and ethics, so to discuss public health's toughest challenges. As we learned from Dr. Mary Bassett today, we honor the late Isidore Ben-Ruby, an esteemed physician who believed that history and science provide the necessary tools for people to make informed decisions on issues of health and human rights. The Ben-Ruby family has been an integral part of our community for many years. Isidore Daniel Ben-Ruby is an MPH graduate and friend and past student of the Center for the History and Ethics of Public Health, who was mentored by Professor Jerry Oppenheimer. He graduated with his MPH and went on to follow in the footsteps of his father and grandfather. While the Ben-Ruby family couldn't be with us today, we acknowledge and are deeply grateful for their commitment to public health, to history and ethics, and its importance in the future of society, and to the Center for History and Ethics. So I'm now thrilled to have Dr. Baer join me at the podium to introduce Dr. Bassett.
Hi, good afternoon. I'm Ron Baer. For those of you who don't know me, on behalf of my colleague David Rosner and Kavita Sivakrishnan, my colleagues in the Center for the History and Ethics of Public Health, I want to welcome you here to this 12th annual Ben-Ruby Lecture. Over the past years, these lectures have sought to examine critical issues that confront public health, and in doing so, we have sought to reflect on the commitments of the center to addressing the socio-political and historical context within which ethical and normative questions of justice and population well-being emerge, are the subject of debate, and as is too often the case, remain unresolved. We have been especially concerned with how class, race, and economic inequalities shape the public's health. In 2014, Joseph Stiglitz, a Nobel laureate in economics and a professor at Columbia University, gave a lecture in which he addressed the question of inequality, how it harms our political institutions, our social fabric, and our well-being. 2 years later, Senator Sheldon Whitehouse spoke of threats to our environment in a lecture titled Manufacturing Doubt, the Industry Playbook for Undermining Science and Thwarting Regulation. Next, in 2017, Paul Krugman, Nobel Prize winner in economics and New York Times columnist, posed the question, does equality have a future in America? And 2 years ago, before the COVID imposed limitations on our Ben Ruby lecture series, Arya Nair, the former director of the ACLU and founding president of the Open Society Foundation, and Jeremy Waldron, a philosopher and professor of law, posed contrasting analyses on the question of hate speech on campus and the First Amendment, an American dilemma. It is with great enthusiasm that we present today Dr. Mary Bassett, who will address the questions of reparations and the enduring challenge of Black-white health disparities. Dr. Bassett's professional life has been marked by a deep commitment to public health and the challenge of persistent inequalities, both here and abroad. Prior to her appointment as New York State Commissioner of Health, she served as New York City's Commissioner of Health. She has also held positions as Director of the Francois Xavier Banyou Center for Health and Human Rights at Harvard University, at the Chan School at Harvard University. Earlier in her career, she was on the medical faculty of the University of Zimbabwe. She then went on to serve as Associate Director of the Rockefeller Foundation's Southern Africa office. There's much more I could say about Dr. Bassett and her distinguished career, but I think that rather than hearing from me, it's time to hear from her. So Dr. Bassett, please come to the podium.
Thank you, and good afternoon, everyone. It's really a pleasure to be here, and I want to begin by saying how honored I am to have the opportunity to deliver the Isidore I. Ben Ruby Lecture in the History and Ethics of Public Health. I'd like to thank Professor Baer for inviting me. His work and this lecture are both a tribute to the importance of history. History always matters, but I can't think of a time when engaging with history was more important than it is right now. I have just learned a little bit more about the origins of this lecture, which was endowed by Dr. Guy Ben Ruby in honor of his father. It was endowed 15 years ago. So it's a lecture for the 21st century, and I couldn't find out that much about the person for whom the lecture is named. But I did find a little bit about his son. Dr. Ben Ruby was, and perhaps still is, a beloved faculty member and an obstetrician gynecologist. He delivered a send-off lecture for graduating medical students that elicited absolute gales of laughter. And he noted that humor was a really important learning tool, including about serious subjects, such as the one we're going to be speaking about today. So that's true, but I'm not going to be able to replicate the use of humor today. And if this remark gets a laugh, it'll probably be my only attempt at levity. The title of my talk is Ending Black-White Health Disparities, the Case for Reparations. And I gave a similar talk about a year and a half ago It had the title, The Case for Reparations for African Enslavement. And at the time, I subtitled it with a question. Time for public health to answer the call? I can't even quite say it correctly. And I probably should not have asked this question, because I knew the answer, I knew it then, and I know it now, and the answer is yes. In the United States, race, ethnicity carves the contours of people's health, with the descendants of those enslaved and the indigenous people found here by European settlers having the worst health outcomes. In a paper that I wrote with Nancy Krieger, when I just finished training in the mid-1980s, we noted that, quote, ever since the first crude tabulation of vital statistics in colonial America, Black people have been sicker and died younger than whites. And I've repeated this fact throughout my working life for now nearly 40 years. It's a fact, but to see this fact as an accusation might not be inappropriate. In any case, it was true then, and it remains true now. As Evelyn Hammond, a historian of science, has remarked, there has never been a time when Black people did not die at higher rates and at younger ages, not a single year. And perhaps this is why this toll is considered normal, but it is not normal. And in tallying across the 20th century in the United States, the New York Times reckoned that without this racial gap, more than 8.8 million African Americans would be alive today. Fundamentally, it is the magnitude of the racial gap and the lack of progress in its elimination that took me to reparations. And over the next 45 minutes or so, I may run over a little bit, I'm going to think out loud and talk about how I've come to see reparations as a path to better health and not a far-fetched idea. And in the end, there may be more questions than answers, and I look forward to a discussion. But I hope that by linking reparations to health, a resource for well-being and prosperity, we can broaden the rationale for a national reparations program. And I hope that these remarks will be valuable to those of you who work in the areas of health disparities and will compel you to engage with this topic. And I'm going to thank people at the end, but I would also like to take a moment at the beginning to acknowledge people who have been thought partners to me as I have explored this subject, both at the FXB Center at Harvard, Drs. Natalia Linos, Dr. Jordan Lawrence, Dr. Jackie John, Professor Jacqueline Baba, Dr. Magda Mataki, and also colleagues in other institutions. Dr. Sandro Galea approached me to write a short piece with him on reparations that was published, as well as Katie Himmelstein, Jean Richardson, and they've continued to work on this topic. So my goal is to bring a public health perspective to the idea that restitution is due to people of African descent in the United States, and that we and people who work in public health, like our colleagues in clinical medicine, can help bridge conversations that occur across disciplines. And also, as we recognize that increasingly there have been declarations such that racism is a threat to public health, not only in this city, but in many jurisdictions across the country. In New York State, at the federal level, the CDC has issued such a call. In general, these conversations have taken place among economists and public policy experts. And I think that we have a role to play in having a conversation about developing proposals about how to repair and redress the impact of holding Africans and their descendants in bondage. So public health has been late to join the conversation about reparations. It's been kept alive mainly by activists and journalists. Within the academy, it's been explored mainly by economists, public policy scholars, philosophers, historians, and I see this as a problem. I think bringing a health perspective means that we can add more numbers to the people who are thinking and theorizing about reparations. And additionally, it can influence the way in which we conceptualize reparations and roll it out. And I think also that we in public health have an area that we've ignored, and that's acknowledging the role that our own field has played in perpetuating racism. We've been ready to identify and decry scientific racism in clinical care. We know that medical teaching founding on the idea that the Black body is simply different than other bodies, that especially white bodies, these ideas have not vanished, and they include the belief in higher pain tolerance, different lung and kidney function, the idea that Blacks have lower intelligence, for example, persisted in the algorithms to calculate compensation for sports-related traumatic brain injury. But public health, despite its foundational connection to social justice, has its own brutal history. And that extends beyond things like the oft-cited Tuskegee study of untreated syphilis that ran until the early 1970s, ended by whistleblowers, remember, and the press, not by any internal processes of the federal government. And even more damaging, I think, has been the uncritical acceptance of the demographic triad of age, race, and sex, which too often considered race as fundamental and intrinsic an aspect of a person as age or sex, and allowed and even encouraged the biological and cultural explanations for racial disparities. The UK acknowledged the role of class in its routine surveillance system, but we have never done that in the United States. I don't mean to question that we need data on racial categorizations, but public health has allowed race-based analyses to result in conclusions that attribute gaps to failures in individuals. So it's time for us to engage in a more direct reckoning with the US legacy of 400 years of slavery, the Jim Crow laws that were enacted following the end of Reconstruction, and to acknowledge that power, money, access to resources, good housing, better education, fair wages, safe workplaces, clean air, drinkable water, and healthier food, which all translate into good health, have been systematically denied to people of African descent. And this is where I need to pause for a minute and note that increasingly these very same resources are being denied also to people who are white. In fact, I remain somewhat stunned. I don't know if you can make this out. This is a graph, I can't even remember where I clipped it, that shows the US life expectancy as compared to other wealthy nations. And it shows the trend that began in 2017. This graph begins in 2019 and was accelerated by COVID. The life expectancy in the United States is declining. At the time, the New York Times, which published these findings, they published a lot of interesting public health data, by the way. They noted that in the US, indigenous people, Native American Indians, now have a life expectancy following the COVID pandemic impact of 65 years. In our hemisphere, this is matched only by impoverished Haiti. So how do we read a community? In our partitioned cities, health tracks with neighborhoods, and we all know visually that we can read a community by looking for litter, the sidewalk and road maintenance, the housing quality, parks, see if they're boarded up windows, police cars cruising. My personal litmus test, and let's see if I can get this to fly in. Yes, is check cashing. When you see check cashing shops, you know that you are in a poor community. And you may not be familiar with this place or this city, but you can predict with almost certainty in our cities that will be a neighborhood where Black and brown people live. And then you can see it in the data. We don't have any guarantee, any one person can have a long and healthy life. but it is a sign of structural injustice if most, if not all, health outcomes for Black Americans are worse than for whites. Why should a Black baby be any more likely to die in its first year of life than a white baby? And as you can see, the relative gap in life expectancy and infant mortality rates has been increasing. Even as overall infant mortality rates drop, the Black-white gap shown there in the line, I don't see, can you see the, yeah, shown there with the black line, shows that the relative gap has been increasing. And we saw this also with the Omicron pandemic last winter. As Omicron swept through, I think all of us felt that this was something that was having an effect that was so universal. Nobody had ever seen such a rapid rise in infection rates as the Omicron virus proved, but it brought with it the racial disparities, the gap between Blacks and whites, who are the red line there, these are Latinos, rose as Omicron swept through the population. Here is a chart that I've used many times as New York City's health commissioner with many different labels. New York City's sickest neighborhoods, how poverty causes ill health. In New York City, the neighborhoods, as you know, are racially and economically segregated, and the neighborhoods that are Black and Latino are low income, have higher rates of housing and maintenance defects, lower educational attainment, higher rates of incarceration. And you can lay any number of health conditions over these neighborhoods. In this slide, they are HIV infection, drug overdose, childhood asthma, and diabetes. And the same neighborhoods, you'll notice, light up, irrespective of these specific health outcomes. And the biological mechanisms that underlie these conditions are truly unrelated. So we have to look to the common drivers. And these are also neighborhoods that were historically redlined. And these these maps are better described as ones that demonstrate the impact of structural racism. And it was for this reason that I created, it's been nearly 20 years ago at the City Health Department, what I called neighborhood health action centers that were designed to address the fact that whole neighborhoods needed to have the most intensive resources of the City Health Department applied, that we shouldn't see each condition separately, but should address these as issues that involve the entire community. And I'm pleased that these offices have survived, now 5 health commissioners, and they're still in place. The current health commissioner, Dr. Vasson, has described these offices as the infrastructure of equity. So these are communities that deserve and need more resources. But I knew then, as I certainly know now, that targeting resources is not enough. The magnitude, the scope, and the scale of health interventions, including many that I have been involved in designing and delivering myself, simply are not up to the task of eliminating this map. It's misguided to think of these communities as just neighborhoods that are full of sick people. So I recognize that reparations will not end racism, but I believe that reparations could bring us closer to the goal to which many of us in public health have committed our life's work, and that is to end racial health inequities. So I also want to acknowledge that my interest in this is also personal. And I want to take a moment to explain how. This is a page from the Henry County Census, Henry County, Virginia. Very often when I talk about reparations, people respond with the argument that this is the past, this is old history, and they wonder why they should be asked to atone, quote, for the sin of their forefathers, and they see no connection between the harm of then and the realities of now. The United States has so sanitized its history that it's left out its brutality. But people who lived through this brutality and told their children of it have not forgotten. My father came from Henry County, Virginia, the same area in which his ancestors were enslaved. I am named for his mother, Mary Travis, who was born in the 1890s. And my grandmother was named for her grandmother. And this first Mary Travis, my great-great-grandmother, was born in 1835. Sorry, did that work? Yes. And she was free. I know that she was free because she was listed by name in the census. The 1860 census was the last census before the Civil War, and until the next census in 1870, people who were enslaved were listed only by age and gender, because, like livestock, because counting them mattered. And remember, the South got 3/4 of a vote for every person who was enslaved, even though obviously they couldn't exercise this franchise. So they were counted, but they weren't named. And in 1870, the first census after the end of slavery, Mary Travis appears again, and now with a Black husband, Riley Parker. On that list that you saw back there, she's listed with a whole group of Morrises. She has, maybe I tell that story somewhere else. She's 25 years old. She has 3 children, including Sam Travis, who you might be able to make out there. He's 3 years old, and he will become my father's grandfather. She had no husband. She's designated as an M for mulatto. And on the page that she appeared, there were a whole bunch of white Morrises. So a historian friend of mine explained that this likely meant that she was a consort to one of these Morrises. And when she was free, she appeared in 1870 with her husband, Riley Parker. So there's a story there. I don't know the story. But we think of slavery as a long time ago. But I knew my grandmother. And she grew up among people who'd been enslaved. So it's only with my generation that slavery will have left living memory. And of course, even after slavery ended, it was followed by the Black Codes as Reconstruction was abandoned, and more accurately, when it was betrayed. And after the Second World War, my father served in the Second World War, he went north to pursue more education. And while at the University of Massachusetts, he met and married my mother, who is white. That's me there in the picture. And my parents' marriage was illegal in the state of Virginia. This was overturned only in the Loving decision by the Supreme Court. The state of Virginia pursued appeals all the way to the Supreme Court. So as a child, we visited my grandmother and my father's family, and I still to this day remember the fear I felt because I'd been told to identify one of my father's sisters as my mother if we were out in public, because in my childhood their marriage remained illegal. And I worried that if somebody asked me the question, "Where's your mother?" that I could get my family into trouble by identifying my white mother. I think everybody who's African American has stories like this. And now let me turn to our topic today, which is the idea of reparations for the enslavement of Black people. This is a long history. The idea of compensation was raised even before the end of enslavement, as early as the 18th century, decades before the Civil War. And in the 19th century, in the years after Reconstruction, Callie Guy House waged a national campaign that was later picked up by the Garvey movement. And more recently, the reparations have been was championed by Black nationalist organizations and the formidable Queen Mother Moore and Cobra, the December 12th movement. They showed up in 2001 at the World Conference Against Racism in Durban to call for reparations for the transatlantic slave trade and colonialism. At that time, a low-level U.S. delegation joined Israel in walking out of the conference. But for many people, it was this essay by Ta-Nehisi Coates that was published in The Atlantic in 2014 that brought the conversation about reparations into the mainstream. Ta-Nehisi Coates is a really brilliant essayist, and he anchored his essay in individual stories that reached back into history to show the centrality of enslavement to the emergence of the United States as a global power. He showed how this legacy was continued by subsequent discriminatory practices that plunged the Black population into a category all its own. A modest hands up was always derided as an unwarranted handout, and Coates quoted Rush Limbaugh as deriding the Affordable Care Act, which I would like to believe is now settled law, as an act of reparations. The American Rescue Act, which allocated aid to Black farmers, was also viewed in the same way. And in early 2021, William Darity and Kirsten Mullen published From Here to Equality, also pictured here, reparations for Black Americans in the 21st century. And they tackled in this book some of the truly nettlesome issues frequently raised about reparation. Who bears responsibility? How do we monetize the cost of reparations? And their thinking has greatly affected my own. And I'm going to use the framework that they proposed in their book to help structure this lecture as we go forward. But I recognize, of course, that this is not the only framework. But as a footnote, I would be inclined to include as beneficiaries all people in the United States who are of African descent, whereas Darity and Mullen proposed limiting people of U.S. descent, people descended from people enslaved in the United States only, to reparations. And I'm also going to add to my conversation the work of Catherine Frank. I'm not sure whether her name is pronounced Frank or Frankie. She wrote a book titled Repair. She is white, a lawyer, and she based her work on archival research and made a very powerful case for reparations that centers on the importance of land ownership as a source of wealth. And as we're going to see, the bill for reparations is not small, and Professor Frank has some ideas about how we might fund reparations here. So it's fair to ask what I mean when I talk about reparations. And I have on this slide quoted some of the definitions of reparations that have been offered by the United Nations High Commissions for Human Rights. And they make the argument that, and I'm going to read a quote here, reparation programs are meant to partially redress gross, systematic human rights violations, not sporadic or exceptional ones. It implies that the universe of potential beneficiaries is large, and they probably suffered various and multiple forms of abuse. Part of what needs to be redressed in the cases that are of concern here is not only a large number of individual violations, but violations that come about in systematic ways, either as a consequence of the deliberate adoption of abusive policies or as a predictable consequence of other choices. Reparations in these contexts must not only do justice to the victims, but also contribute to reestablishing essential systems of norms, including norms of justice, which are inevitably weakened during times of conflict or authoritarianism. So this really tilts the case for reparations to cases of mass atrocities such as genocide. And in 1951, William Patterson presented in Paris a petition titled "We Charge Genocide" to the United Nations on behalf of Black Americans. He argued that the goal has not ever been to eliminate, at least not so far, to eliminate Black people, but that group membership alone was reason enough to be killed. So he, theorizing on what are worthy situations for reparations, I think would benefit from public health input. There is a Lancet Commission on reparations. Its work was disrupted by the untimely death of Paul Farmer. But it's clear to me that, and in this, I had conversations with Jackie Baba, who's a human rights lawyer who was at Harvard with me. She's still there. That atrocities based on group membership is key. And I promised always, when I talk about reparations for people who are descendants of enslaved Africans, to mention the indigenous people of what became the United States, for whom encountering European settlers resulted in genocide and land seizure. It truly catastrophic. We talk about the declining life expectancy of people in this country, but life expectancy has been declining in successive birth cohorts beginning in 1948 for American Indians and Alaska Natives. But today I'm focusing on people descended from the descendants of enslaved Africans. So I think of reparations as something that is necessary when the harm that was done cannot otherwise be remedied. So there are a number of options for ongoing harms, not the least that these harms should cease. But past events are in a different category. And in this case, justice calls for compensation for nearly 250 years of African enslaved labor and a century or so of legal exclusion from full citizenship, which was often enforced by terror. Of course, it can be difficult at times to disentangle the impact of injustice, for example, the stalling of intergenerational wealth transfer due to redlining, from ongoing gentrification, housing discrimination, and so on, that have to be addressed contemporarily through policy and law. But it is important to acknowledge that there are situations where there can be restoration or reversal of the harm. And where it's still possible, these reparative actions should be taken. And in my eyes, these are not reparations. The loss of the Louisiana waterfront or Manhattan Beach, these were properties where the land could still be returned. But in contrast, I think of reparations as restitution for historical harm that cannot be undone. And there's also the issue of scale. Many private actors, including academic institutions, are beginning to reflect on their engagement with the use of enslaved labor. We all know that Georgetown University began such an exploration. Harvard University is doing the same. Georgetown, of course, to establish itself, sold 272 enslaved people down south in order to raise funds. But the scale required to match the harm inflicted by enslavement and what followed can't be addressed without the action of government. And it is on the federal government that Darity and Mullen place responsibility. I'm not a lawyer, but I think that Frank leaves more options for state level action. So Darity and Mullen proposed this framework, ARC. And I think probably they were thinking of the famous quote that used by Martin Luther King, "The arc of the universe is long, but it bends towards justice." And they outline A for acknowledgement, R for redress, and C for closure. Acknowledgement is the admission of responsibility for the atrocity or atrocities by the culpable party. And I'm quoting Darity and Mullen on this. The admission should be accompanied by a guarantee that to make restitution and to not repeat it. Redress is the actual restitution, typically in the form of monetary compensation. And closure means that the victimized community and the culpable party agree that the debt has been paid and that the victims will make no more group-specific claims unless some new atrocity occurs. So I'm going to begin with acknowledgement using this framework, because clearly acknowledgement is a form of truth-telling, and it includes recognizing in public health our role in propagating scientific racism, which lent a sheen of science to white supremacy that still lingers. We permitted human experimentation, the terrible stories of Tuskegee, of Marion Sims, who operated on enslaved women to perfect the repair of a birth injury, vesicovaginal fistula. There's Henrietta Lacks, whose cells founded the HeLa cells, whose cells were used without her knowledge and consent. And of course, in organized medicine, and this is not so much public health, the AMA, which was founded in 1847, apologized only in 2008 for its many decades of collusion with segregated health care and their exclusion of Black physicians for over 150 years. So we continue to have a very unequal health system, and we have atrocities that should be acknowledged, and apologies are due. But often when we talk about these issues, we're talking about personal racism, racism in personal health care, and the interface between a provider and a patient. And it leaves out the ways in which these inequalities are structured. Here is an example by the two Himmelsteins, Gracie and Katie, that show that hospitals that serve many Black doctors have many fewer assets, including the types of equipment that are needed to offer standard of care. A recently published paper by them showed that there are also huge fiscal disadvantages to hospitals that serve mainly Black patients. The paper calculated that equalizing reimbursement levels would have boosted Black serving hospitals' revenues by about $14 billion in 2018, or about $26 million per Black serving hospitals. So, you know, these are not a matter of how your doctor felt about you or how they interpreted your complaint when you saw them. Even if your doctor wanted to provide you with good care, it might have been quite difficult to do so at one of these hospitals. I certainly encountered this when I trained at Harlem Hospital, when we didn't have a CT scanner, for example. So even if we wanted to practice standard of care, we did not have the resources to do so. And I mean, there's some amazing figures. It's amazing to me that that something over 40% of Black patients who receive Medicare receive their services in between 10 and 15% of hospitals, which shows you how partitioned our healthcare infrastructure remains. And this is a graph that I return to often. And I was just reflecting on the fact it took a lot of work to create this graph by Krieger and colleagues, and it hasn't been updated since 2002. So it shows for all people of color, these lines on the bottom are white people, and the separate lines are quintiles of county wealth. So these are the mortality rates. So this is the quintile of whites in the highest quintile counties. And you can see here, and this is of people who were people of color. And until quite recently, this group was overwhelmingly people classified as Black. And you can see that it was only in the early 1990s that the highest income quintile of people of color matched the lowest income quintile of people classified as whites. So these data are important. I think that these data can be used to, to make the case that we have a problem not only with class, but also with race. And they also, Krieger points out, that there was a narrowing of these gaps in the years that followed the many progressive legislations that were part of the Great Society era. So that social policy really has an impact on premature mortality rates. These were deaths before the age of 65. And she found some pretty incredible statistics. For example, it was only in 1995 that Black men achieved a stable life expectancy of 65 years. And this was achieved by the white population in the 1940s, by Black women in the 1950s. So Krieger, but probably the most important observation here is that the racial gap narrowed during a period of progressive social policies. So we have a lot of data that can help us acknowledge the damage. And we also saw this during the COVID pandemic when we saw much higher mortality rates. And these are rate ratios. So this means that that in this age group, 35 to 44 years, Blacks were 9 times more likely to die of COVID-19. This is based on data mainly from the first wave. And this is staggering to me. I know everybody worries about case fatality rates, but I really do believe that this was driven principally by exposure. We just don't see rate ratios this high related to the common causes of death, by that which I mean diabetes, heart disease, cancer. And this had to have been driven by unequal exposure, who were the frontline workers. And I don't have time to go over all this, but we got education data, and this showed that even when you consider education as a proxy for social class, racial differences persisted. And in this group, who were adults 25 to 64 years of age, nearly 90% of the deaths in this group due to COVID-19 would not have occurred if they had the same mortality rate as college-educated whites. So, we clearly have ample evidence that we should acknowledge of the impact going down through the decades and centuries. And let's turn now to the remedy. And I'm going to talk about also the remedy that has been proposed by Frank. So Darity and Mullen argue, and I think convincingly, that the summary metric that is the most important measure of the impact of many years of enslavement and the discriminatory treatment that followed is the Black-white wealth gap. And the most important actor is national, that is the federal government. And they assess the wealth gap as about 10 to 1 for Blacks versus whites. And to eliminate this gap, the product of uncompensated labor and many generations of exclusion based on 2019 data. So the price tag has only increased since then at a cost of about $850,000 per household. It would be $10 to $12 trillion. So that's a very big number. But they argue that this is the only number that will result in meaningful repair, is the elimination of this gap. So what would this do for health? Because I think it's important often to say, right, there's an important moral case to make that we should eliminate this wealth gap that is unfair and resulted from bad policies. But it would be good to be able to point out that we would get other benefits, including benefits to health. And, we've seen this also in all the arguments about climate change, that we don't just want to save the environment. We also have many health effects related to climate change. So I think it's worth thinking about what this would do for health, what we would save in terms of all those emergency room visits and hospitalizations and premature death that now occur in excess among the population of African descent. These are high cost occurrences, not only because the United States spends more money than any other country on healthcare. Gosh, I really should pick up the pace here. So I wanted to tell you a little bit about these experiments that have been done, and these are all thought experiments, and there are two studies, one of them which has been published by Richardson and others, that showed that if we had eliminated the wealth gap, that we would have seen both reduced exposure to COVID in the Black population, and we would have seen less onward transmission, right? If you have fewer infected people, you'll have less transmission. And that there would have been a reduction in infection by 1/3 to 2/3, which would benefit the entire population. So they use an example of what eliminating the wealth gap would have had on COVID. This was published in Social Science and Medicine. And another study that thankfully has recently been accepted. It's really hard to get this work published, I should point out to all of you. That this is a study based on the health and retirement study. It's of people 50 and older. And among these middle-aged adults, they modeled what would happen if to the risk of death before 65 years. So that's a premature death. If we made the wealth distribution equal at the beginning of the study. And they found that the differences in wealth largely accounted for the fact that there were a much higher mortality rate among these middle-aged Blacks, and that reparations, if it eliminated was made equal prior to entry into the study, the mortality gap would have been reduced by half, and if you included income and education, it would have been entirely eliminated. So then there's Frank's work, and she does a lot of work based on archival research in two places, the Sea Island and Davis Bend, which was a plantation owned by Jefferson Davis. I don't know how many of you remember that he was the nominal president of the Confederacy. And so she makes the case that the emancipated Africans were freed rather than free. And the case that freedom is more than the absence of bondage. She reminds us that the request at emancipation was for land. Land was promised, deeded to the newly freed population, and at a stroke of a pen, after the assassination of Abraham Lincoln, more than 400,000 acres of land that had been distributed to 40,000 formerly enslaved people was returned to its white owners. And she points out that the newly freed were like people on an island told that they were free to go with no boat. So the newly freed were really left with no choice but returning to serf-like conditions of sharecrop labor. And she makes the case that what's due is community reinvestment, not only individual household cash handouts, which Solidarities propose. And she points out that at the very same time that land was being taken back from the newly emancipated enslaved people, the Homestead Act made literally thousands of acres, 160-acre tracts, available to mostly white European, many of them immigrants, who settled these lands in the Midwest. It's estimated that over 90 million Americans alive today are descendants of these homesteaders. And it's true that some Blacks also got land. Some Blacks managed to hold on to their land. But we can't forget that the kind of terror that was wreaked upon Black wealth. Now all of us know about the Tulsa Race Massacre, but many of us don't know the cost that was paid by people who sought to retain their land in the U.S. South with the rise of the Ku Klux Klan and so on. So Frank's idea is to tax the baby boomer inheritance. She estimated that $59 trillion is going to be transferred from 93 million estates between 2007 and 2061. And she argues that the beneficiaries, the generation of baby boomers, should renounce some of this racially tainted land and fortune and redirect the bounty to the cause of racial justice in our communities. And obviously, inheritance tax is mainly a federal issue, but there are states that do an estate and inheritance tax. And there has been a new bill. It was voted out of Congress for the first time, out of committee in the House of Representatives for the first time, H.R. 40, a reference to 40 acres and a mule. And it is, it is now at least out of committee for the first time since it was introduced 30 years ago. It hasn't gone to the House floor. Obviously, the main issue, I hope that I have served to convince you that there is a price to pay for the history that I have recounted, and that we're paying a price in premature death and excess mortality, which seems to be a price that's being paid by the United States population across the board. But obviously, creating the political will for reparations is a big challenge. In the Caribbean, reparations is a state project of CARICOM, which is their Caribbean Union. They have a commission. They have entered into agreements for reparations from the United Kingdom, for example. And there's not much support for reparations among the white population of the United States, but this proportion has risen. It used to be 4%. Now it's about 30%. And of course, we have, the idea of reparations at local level spreading across the United States. But there are also other strategies that are not directed only to Black people. And I've listed some of them here. There's baby bonds, which would give every baby, it was invented first in the UK, give every baby sort of a bond at birth and give the amount according to income, which would tilt it towards people of color who tend to be poor. Obviously, Medicare for all would be an equity, a pro-equity maneuver, ideas like basic income. What Frank wanted to do was land trusts. And I put this next slide in just to remind myself to mention community land trusts, which exist around the United States. She really believes that rather than individual cash payments to households or individuals proposed by Darity and Mullen, that there should be an effort to secure wealth by creating trusts that are held in collective hands. And I think in public health, we are interested in the collective. We think about the population, not just individuals. And there's been a price to pay in terms of institutional costs, as I've mentioned when talking about hospitals. So I think this is an interesting idea. Frank doesn't think that it's wrong to give individuals or households money, and the Darity Mullen team, they happen to be married, don't think it's wrong to talk about collective compensation, but they think no form of compensation should be done that doesn't include individual payments. And then there's closure, and I don't really know whether we are ready to even begin to explore closure. Last year, more people died after encounters with police than in any year in history since we've gathered these data, more than the year of 2020 when George Floyd was murdered. And they continue to represent disproportionately Black men who are also less likely to be armed, less likely to be threatening. And of course, there's the problem of mass incarceration. So I end with a reflection on the arc of our history. This graphic by a Baltimore artist should remind us all how much of the history, he uses the traffic light colors to remind us that the light only turned green in 1954 for people of African descent. And some people, this is Brown versus the Board of Education, that made school desegregation the law of the land. Some people would say it should be later with the Voting Rights Act and the Civil Rights Act. And of course, as I've been arguing, it isn't really green yet. But I will end with the words of Martin Luther King, that the arc of the universe is long, but bends towards justice. Reparations won't fix racism, but a less impoverished Black America, where the historical origins of its burdens have been acknowledged, would be better placed to protect our future as a nation, the future of all Americans. And I'll just thank again the same people. I also added my daughter, who embraced reparations as a strategy far before I did. And I'd be happy if there's still some time, as I've run over, to have some questions from the audience. Are you going to do the? No, I don't know.
I
can-
would just like to say thank you very much, first of all.
Sure.
I'd like to say that there are 200 people that are watching this online. We confront a challenge of getting people to go into collective spaces.
Sympathize with
But
that.
I'm very pleased that you are here, and I hope some of you will have questions for Dr. Bassett. So would you identify yourself when you go to a mic?
I want to acknowledge also this really beautiful graphic that went out to advertise this lecture. And to thank those of you who came. It's really hard to give a talk with no audience that you can see.
I'll just start it off. Given the current political climate and given the realities of the dissembling of the United States of America, what prospects do you see for the coming years, and what kind of legislative political actions do you see as possibly addressing this?
Well, there's no question that we're in a very difficult period. And to be honest, I'm not really sure how it's going to go. You've caught me in a week when I'm feeling kind of gloomy about it. I still feel that there's always a role, especially in academia, to speak truth to power. I really do believe in the words that I have written and may have said this evening or this afternoon, that if, as a nation, we don't confront the legacy of African enslavement and the genocidal campaigns against indigenous people, we'll doom our future. We have, I just don't see a way out to make this a country that honors the soaring words of its founders. But to the extent that I think that this is legislatively feasible, as I mentioned, H.R. 40, which doesn't mandate reparations, it just sets up a committee to study it. So I would put it under the category of acknowledgement, not really, action. The likelihood that it would pass the Senate in any time, it was never great, but it may not be anywhere near possible after November. And it still hasn't come to the floor, even though, at least half of the Congress has indicated a willingness to support H.R. 40. So, but it's out of committee for the first time in 30 years, and that was no doubt related to the mass alarm following the murder of George Floyd.
Dr. Bassett, my name is Carlos Cuevas. I'm an alumni of the Mailman School and former board member. Again, sincere thanks for coming and speaking with us tonight. In terms of ending black-white health disparities, right, you spoke about basically the remedy about restitution, redress, and repair. One other R that I think should be on there is representation. And one thing that I would like to know about is in your role as the leader of healthcare in New York State within the New York State Department of Health, we actually don't necessarily see a lot of ethnic diversity in our leadership in Albany. We have representation from downstate, which is nice, which wasn't there before, but especially in the Medicaid office. As you know, Medicaid is a $92 billion program. It's over 40% of the New York State budget. And we actually do not have any brown, black, African-American, Hispanic, or Asian leadership, especially when we're proposing a $13 billion waiver proposal to promote health equity without any leadership in that office, being of an ethnic background or being from New York City, which we know had a lot of health disparities during the COVID pandemic.
Well, most of what you've said is a statement of fact and not a question. But what I can say is that, first of all, that the political leadership is aware of this issue. They've established an office. And within the state health department, I recently established an office that's called the Office of Health Equity and Human Rights, that's led by a person would be classified as African American, whose task it is to bring this lens to the work of the entire department. But you're right to say that the health department should look like the people of this state. I'm not going to stand and deny that your facts are not reflective of an actual issue that we need to address. It won't be changed immediately, but I want to thank you for raising it. It's a good point. We have no Latinos, for example, in the leadership of the health department, although we do have a handful of African Americans. Yeah.
Hi, Dr. Bassett.
Oh my goodness. Hi.
Kimberly Mack from New York City Department of Health and Mental Hygiene. I got two questions for you. I've often heard Brian Stevenson in the past speak about reconciliation and talk about how South Africa went through a reconciliation process, and that he thought that was very important. And I got the chance to ask Dr. Melissa Harris Perry her thoughts about it, and she had a very interesting take on that, that had to do with the fact that South Africa, what they did was didn't have the vast span of time that the U.S. and our 200 years of slavery had, and the deeply rooted racism that has grown over that period of time, and of course before then. And so I wanted to know what you thought about reconciliation in its place here in the United States, and just what you thought about
Sure.
it and the role.
Yeah. And so you're referring to the Truth and Reconciliation Commission that was established at the end of apartheid. The newly elected government decided that rather than litigate every single atrocity that was committed during the apartheid years, that they would seek truth rather than punishment. And so they asked people to come forward and basically confess to various crimes, and in return, they would not be pursued criminally. And the idea was, that wasn't what I wanted to do. The idea was, so I think that the A in ARC is equivalent to that. That the A being acknowledgement. Really, what the Truth and Reconciliation Commission did was say that acknowledgement is enough. But let's see the differences. This was a country in which, the baton had passed to the African National Congress, a black majority country that was now going to be led by an organization that fought for the rights of the black majority. So that's really a very big difference from the United States, where people of African descent remain a minority. But I think that what I would say is that we just can't overcome the kind of inequalities like a 10-to-1 wealth gap by telling people just work harder, which is basically what the message is. You should just work harder. We worked hard, never mind that 93 million of us benefited from 160-acre allocations that were taken. This was not empty land. This was land from which indigenous people were forcibly removed. And as long as this kind of gap exists, it's going to take state policy to overcome it. So I don't think that the A would be enough. I think that we have to have a form of restitution. We've seen advances. I mean, I highlighted the relative gap in infant mortality rates, but I hope you all noticed that the infant mortality rates have plummeted. So they're lower for everyone. It's the relative gap that represents many fewer black babies who lose their life in the first year. But the gap is still there, and it's unfair. And I think that it will take actually a federal action to acknowledge its origins. I don't know if that answers your question, but thank you for that.
Also, I see you use, and we do this in public health, we use history. We put history in there so people can see incidences. I think that's data itself. History is data itself.
I think that's a good point to make. I think too often we think data are just numbers. And thank you for making that point. So yeah, let's give it a.
Do you think
I think if there's one thing I would tell people we need to do, we need to learn more history.
Okay, so we need to use it, really use it.
Yes.
Okay.
I consider myself pretty well educated. I knew about Tulsa decades ago, but I didn't know about about Wilmington, North Carolina, where the legislature that included elected black officials was basically run out of town by a gang of Ku Klux Klan type people. I didn't know a lot of things. I didn't know how much black land had been lost to Southern terror. I didn't, until Isabel Wilkerson wrote about the Great Migration, I wouldn't have been able to tell you that that was the largest unorganized movement of people in a country in history that's documented, and it was to escape terror. People didn't move because they were looking for better weather in Chicago. They moved to escape terror. So if it's a single thing I would say is that we should learn more history, and the history are facts, are data. Thank you for that comment.
Hi, Dr. Bassett. My name is Kyle McDonald. I'm an alumni of the school. And I had a question just about the precedent for reparations, which I think is really important.
Yes, I didn't mention that.
The
Yeah.
government has provided reparations before, especially for Japanese Americans
It did.
interned, and also, I believe, a group of Italians in the 1800s after a lynching
Oh, I didn't know about
in
that.
the South. So I was hoping you could just share a little
Yeah,
bit.
no, I mean, what I know is from what I've read, but reparations is not unprecedented. So reparations were made to people who were interred during World War II, Japanese Americans. Reparations were made to the victims of the World Trade Center attacks. These were cash reparations to individuals. So this has happened. Of course, there were reparations for victims of the Holocaust, including reparations paid by the United States. I had in one of my classes at Harvard a student whose grandparents were still receiving, they must be quite old by now, reparations from the German government for the Holocaust. So there is precedent. I think, yes, so there's precedent. And I didn't know about the Italians, but I'll have to look that up. Thank you.
Thank you.
Yeah.
Commissioner Bassett, thank you for a really important talk. I've been talking a lot about a recent book by Ron Daniels called What Universities Owe Democracy. And in the spirit of that title, and the substance of the book supports it, that there is a case that universities owe democracy a fair amount, and this is a critical moment to deliver. I would value your thoughts about what we as a school of public health need to do more of or differently in the coming years to support this, not just the case for reparations, but of course, what else we need to be doing as well in terms of our part of resolving health disparities.
Well, this is not a simple question, but the question really is what should be the role of the university in addressing the enduring legacy of African enslavement and its impact read on our bodies as health disparities. And one of the things I think is also, remedial. I think I didn't study public health here. I didn't have a center like yours. But I think that it's a good idea for part of the teaching of public health to include requirements for learning some history. And I think that history should sort of be a little more complete than the history I read. I remember finding George Rosen's book. Have I got his name right? Okay. It's History of Public Health. I was so excited about this book. And it was hard to find for a while until it was reissued, reading it cover to cover. And it's a wonderful book that shows the important role of public health in social advancement. And you could read it cover to cover and hardly learn anything about race in the United States. It's not in there. I didn't notice that till years later. So I think that, having a more complete history, and I don't know whether anybody noticed my critique of the triad, age, race, and sex. And I think that we need to unpack that. Why we in the United States have decided that race is part of our bodies and rather than part of our society. So introducing this kind of critical thinking, I think the other challenge, of course, is to link to your communities. Most hospitals are in poor communities where they got, quote, clinical material. I'll use an example of another school of public health, one to the south of here, where I was visiting somebody, and he looked out the window. I'm talking about Johns Hopkins. I hope they won't mind. Okay. He said, look out there. This is like one of the poorest, some of the worst health outcomes in the United States, out our window. And I'm like, what? Your university has been here all this time, and you're talking about it like it's a wonderful research opportunity? I think that we all should try harder to address our backyards. Where I sit in my office now at Empire Plaza is in a historically Black red-lined community, which Governor Rockefeller carved in half, much as 95 carved the Bronx in half, to build this monument to his idea of Brazilian modernism or something. It's quite stunning, but it was very damaging to that community. So those are the two things that I would talk about: how we think about data, how we include history, and how we connect to our communities, I think are all academic tasks.
Thank you.
Are you about to relieve me? The questions are getting harder. All right. No, I'll take the last two and then we,
There's a
yeah.
reception outside,
Okay.
and it's going to disappear if you don't find it soon. So, go ahead.
Hi, my name is Leslie Alvarez. I'm here, one of the MPH students. Thank you for coming today first. I have two questions. One, what does reparations look like in the U.S. Virgin Islands and Puerto Rico, given that there is, a big...
You mean about colonialism?
Yes.
I see. Well, that's another issue. It's different.
Oh, okay.
It's worthy of reparations. Indigenous people have a case to make, but it's different.
And then what would reparation look like when the trauma is generational, like in the case of epigenetics, where our ancestors' trauma has physiologically and
Yeah.
biologically changed us? What does
Yeah.
that look like?
It's interesting. I'm from the generation that really worried about material deprivation. But many of the younger people I work with talk about the enduring impact of trauma, which is read on our bodies and seen in epigenetics as an important emerging area. It's not talking about the genetic code, it's about sort of how it's modified by our environment. So, I just think that, as I said, reparations won't fix everything. But I suspect it would fix quite a bit. I don't think that we can underestimate the pain of of working against unfair economic odds, always. And so I think you raise a good point that there are many dimensions to the harms. Not all of them are measured materially, and all of them matter. But I really have been focused on the concept of monetary reparations, either collectively, individually, or both.
Thank you.
And how they might work, yeah.
Good evening, Commissioner Bassett. Thank you so much for speaking with us. My name is Tyler Nichols. I'm also a first-year MPH student here. And I had a question more so about the logistics, because I completely agree that reparations are needed, but I was wondering what the action plans for implementing or dispersing.
Oh, there's no action plan. Let me just be very clear about that. We have HR 40. We have individual jurisdictions. Some of them have, Evanston, Illinois has actually released funds. But I think that it's a new framework, is what I'm making the case, that so often the dominant idea is that the conditions of the Black population is due to some form of defect, that there's been a cultural defect. People just didn't know how to get out there and work hard the way immigrants did, without recognizing the material differences. So I think in many ways we're at the A part of the arc. The action plan is not there. The Darity and Mullins would say that we owe every Black household that can show that it's descended from a person enslaved in the United States $850,000, and that the price tag nationally comes to 10 to 12 trillion. Frankie has a different perspective, arguing for collective compensation in the form of land trusts. But both of them share the idea that we have to take an action that's not, that doesn't just invoke individual effort. And that it's a government project. And with that, should I thank everybody for their attention?